Evening, sir.
Good evening. Bhaskar, all set?
Yes, sir. All set, sir.
Yes.
Is it live now?
Yes, Bhaskar, it is live. I'm sharing it.
Anjali, the video page is not available. I think you can stop. Yeah, ma'am, the YouTube page is live now. Probably we can start with the as per the schedule, ma'am. Now,
Right. Thank you.
Anjali, stop sharing your screen.
May I start?
Yes, ma'am. We are good to go, ma'am. Yeah.
Good evening, everyone. A big warm welcome to today's lecture on twins, double trouble, as they say. So before we begin, let me first wish you all a very, very happy Republic Day. It's a great evening, and we are very fortunate to have none other than Dr. Bijoy Balakrishnan, who in the world of fetal medicine really does not need any introduction. He is an established leading name in the world of fetal medicine. He's a lead consultant at Simar Cochin. And on the behalf of MSBIRI and MCR, I take great pleasure in welcoming him tonight. Now, before we begin, just a few instructions to the delegates. When they visualize the YouTube page, there's an option down below which says interact with us, where you can type your questions and the questions will be shared with Dr. Bijoy at the end of the lecture. Over to you, sir, Dr. Bijoy Balakrishnan.
Thank you. I'll just share my screen. I hope my screen is visible.
Yes, your screen is visible, sir.
Good evening, everyone, and happy Republic Day to all of you. And thank you for joining for this webinar and also for this opportunity for me to be here. I hope you're all charged up for a twin session where we're going to talk about fetal growth restriction specifically when it comes to twins and how to manage that specific problem. Now, in singletons, our job is slightly more easier. I hope my slide is changing. Sorry about that. Yes.
Yes.
When we talk about twins, it's always a good news for most of the people, except for the treating obstetrician and the fetal medicine specialist, because most of the times you're worried about what are the complications and somehow you forget to enjoy the journey of being in a twin pregnancy. And that's why for most of it's always a bad news. But when you think about growth restriction, In singletons, it's a little bit difficult because we need to decide how to manage the small baby and also look after the mother as well. So it's a toss between trying to save the mother and also save the baby, and also bring the baby out at the right time, which in itself is a task. In twins, to that complication, we have another problem, and that is an AGA fetus. Apart from the baby that is going to be hypoxic and is going to be having IUGR, we are also worried about the AGA fetus and how we get that baby out alive. Now, in monochorionic twins, it's even more complicated because we know that this small baby, if it dies in utero, it's going to put a lot of risk and confusion in the management of the AGA baby. And that's why in monochorionic twins, the problem becomes even more difficult. So singletons, we know what to do because we want to prevent the baby from dying in utero, and we also need to protect the mother. In DC twins, we know that there is an AGA baby that we need to take care of. But in MC twins, there is a huge risk of the smaller baby dying in utero, and that in itself can cause a lot of complications. So the first thing is basically, how do you make the diagnosis of growth restriction? What is the idea of, and how are we going to manage these fetuses and know whether they're actually small or not? And for that, the first thing, or the elephant in the room, is going to be on which growth chart to use. And if you look at twin pregnancies, you know that twin pregnancies are going to be smaller than their singleton counterparts. You know that they're going to be smaller when you compare them for age, gestational age, and they're going to be smaller by around 1 kg. So if that is the case, shouldn't we have separate charts? And that's what Gardosi said way back in 2005. He said that in twins, you need a separate chart because these twins are going to be mature much before than your singletons, and they're going to reach 40 weeks at around 37 weeks. So why shouldn't we have separate charts? But that is actually done under a very wrong assumption. Because if you look at the perinatal outcomes as far as twins are concerned, they are much worse when compared to singletons. And if their growth slump is indeed physiological, then there shouldn't be this change. And therefore, there must be a pathological cause which makes these babies smaller, and probably they're not reaching their growth potential. And that's why using separate charts is slightly risky. The argument against that was when this study came out by Baski Tilaganathan's group in 2019, where they said that it is better to use twin charts for twins and thereby improve the outcomes. But in that study also, they very specifically said that if you're using Doppler along with your growth scans, then there is no specific advantage of using a twin specific chart. So if you can use your singleton charts, but at the same time, you have to be sure that you are using Doppler in each and every one of your growth scans. And when you do that, the risk of underestimating or overestimating growth restriction is quite less. And therefore, the take home on growth charts would be to use singleton charts, monitor growth frequently, and understand that a growth scan is not complete unless you do a Doppler evaluation as well. The next question that needs to be addressed when it comes to twins is the matter of discordance. Now, discordance basically means that when one twin is smaller than the other, it's like having a benchmark, and the larger twin acts as a benchmark against which the smaller one is compared. And if you find that that discordance is above 25%, that means if the difference between the larger twin and the smaller twin is greater than 25%, then there is a huge risk of perinatal complications, and we need to look after these babies a little bit more closely, irrespective of the fact if both the babies are above the 10th centile. So if there is a difference of 25%, even if these babies are above the 10th centile, we need to be a bit careful. Now, the reason for discordance is different in dizygotic and in monozygotic pregnancies. But it's difficult for us to say zygosity, and therefore we look at chorionicity. In monochorionic pregnancies, we assume that these babies have the same genetic makeup. And therefore, if one baby is smaller than the other, then it could be because of anomalies, or it could be because of growth restriction. In DC twins, yes, it could be because of anomalies or aneuploidy or growth restriction, but there is also the possibility that because they're coming from different embryos, majority of the time, there is a chance that they could have differing growth potentials as well. So in Dichorionic pregnancies, when one baby is smaller than the other, it's not necessarily bad news. It could be because one of them has a lesser growth potential than the other one. Now, once we have that out of the way, we've got understood that there could be a possibility of growth restriction without discordance. Let's understand how DC twins are different from monochorionic twins. Now, in DC twins, the most important understanding here should be that they are smaller because of a bad placenta. They are smaller because of uteroplacental insufficiency in exactly the same way as in singletons. So in DC twins, you have two placentas. One placenta is bad, and that's the reason why one baby is small. And because of that, there is a higher incidence of preeclampsia in DC twins that have growth restriction as compared to MC twins that have growth restriction. So uteroplacental insufficiency is the key there, and we have to do serial growth assessment on a monthly basis, use singleton charts, and use your Doppler in every visit. And so how do you make the diagnosis? Now, the diagnostic criteria in DC twins is exactly similar to singleton pregnancies, the only difference being the addition of discordance. So if there is a discordance of greater than 25%, along with a baby being less than the 10th centile, or having an umbilical artery abnormality that is greater than the specific advantage of using 95th centile. I think there is an echo coming from somewhere. Yeah. Okay, so if you have discordance along with one baby being less than the 10th centile, or just discordance with everything else being normal, even then it is a cause of concern. So there are two or three types where you could get a baby that is small. So here you have one condition where you look at the growth chart and you can see both babies are growing well. And then you have this condition where two babies are showing discordance, but both of them are above the 5th centile. So here you have discordance, but not necessarily the babies being smaller or lesser than the 10th centile. And then you have this variety where you have one baby that is clearly falling off the chart and the other baby that is sitting normally within the 50th centile. So the important point there to understand is that you can have growth restriction without either of the babies falling less than the 10th centile. And that's where Doppler becomes extremely useful. Now, if you have one baby that is small and one baby that is growing well, and the smaller baby has got a Doppler abnormality, so naturally you're worried about the smaller baby dying in utero. So the first thing we need to understand that when the smaller baby dies in utero, it does not put the mother at any increased risk. So there is no increased risk of DIC as was previously thought. And most of the times when one baby dies in utero, the mother is perfectly safe. So that's the first thing that we need to understand. The second thing we need to understand is that in DC twins, when one baby dies, it does not put the other co-twin at risk because they do not share a vasculature. So basically the problem in DC twins is the dilemma of when to deliver and how to time your management. So the question is, if you have two babies that are small and one baby is showing a Doppler abnormality, do you take the decision to deliver the smaller baby or do you wait till the larger baby is more mature? If you take the decision of delivering based on the smaller baby, considering that the smaller baby is going to die in utero and you want to save both the babies, you run the risk of iatrogenic prematurity of the normal growing baby, and thereby you put the larger baby at risk. But on the other hand, if you decide to deliver based on the larger baby and you decide to ignore the smaller baby, then the risk is that the smaller baby could die in utero. And there is even another risk of having a smaller baby that survives till term and becomes handicapped. And that's the dilemma. Do we wait and decide that we're going to deliver based on the larger baby, or do we wait and just say that, okay, I'm going to try to save both these babies? And that was answered by this paper, which is the only paper that has looked into this, where they tried to go in for expectant management for DC twins with growth restriction and decided that they would not do anything till 32 weeks. Irrespective of the condition of the smaller twin, they would decide to carry on this pregnancy till 32 weeks. And what they found out was pretty interesting. They found that when they decided to do nothing till 32 weeks, 35% of the growth restricted babies died in utero, but all the AGA babies survived, except for two that had preterm labor, and that was nowhere related to FGR. and one baby survived with handicap. But the good part here was that majority of the babies that reached term are healthy. We would lose out on 35% of growth restricted babies, but all the rest of them would survive without handicap. Now let's look at the alternative. The alternative would be to decide to deliver based on the smaller twin and try to save both these babies and try to not lose that 35% that we would have lost if we decide to go up till 32 weeks. When you do that, look at these numbers. If you decide to deliver based on the smaller baby, you will, yes, improve the survival of the smaller baby by 70%, but all those small babies that you're trying to save would have severe handicap. 70% of them would have the compounded handicap of prematurity along with the problems of growth restriction. And look at the AGA babies. Now, these AGA babies were comfortably growing in utero, and you decided to pull them out to save the IUGR baby. And when that happened, look at their survival. Only 40% of them survived, and out of that, 25% of them would have severe handicap. So going early and trying to save both those babies is not acceptable. You need to find a solution whereby you will try to save the larger baby, and the onus is on keeping the larger baby alive and thereby improving perinatal outcomes. So that's what has been followed so far and was brought out in this paper by Vaski Tilaganathan, where they said that don't wait till 32 weeks. Bring down the gestational age to 30 weeks because that's how good your NICU is. So let's not do anything till 30 weeks. And at 30 weeks, you can decide to deliver based on the condition of the smaller baby. And depending on that, you can decide whether you want to wait till 32 weeks or 33 weeks or beyond. And if one baby dies before 30 weeks, then you push this pregnancy till around 36 weeks. There is no role for early preterm delivery if one of these babies dies. So the idea and the take home here is that if you have FGR, you don't do anything till 30 weeks in a dichorionic pregnancy. And at 30 weeks, you look at the smaller baby and see how the smaller baby is behaving. If there is DV reversal, then you can go in for direct delivery. But if the umbilical artery is showing, say, absent end diastolic flow at 30 weeks, it means you can wait till around 32 to 34 weeks. And so use the same criteria that you used in singleton pregnancies. That is, if there is reversed end diastolic flow, you would deliver between 30 and 32. If there is absent end diastolic flow between 32 and 34, you would deliver, and you would go in for delivery irrespective of the gestational age if you get late decelerations or an abnormal biophysical profile on your CTG. And you would go in for elective delivery for all by 36 weeks if there is growth restriction. And if one baby dies, you would push this pregnancy to 36 to 37 weeks. There is an entity called as late onset FGR in DC twins as well, and it's exactly the same as late onset FGR in singletons. Here, one baby is going to growth restrict, or the discordance is going to be beyond 25% after 32 weeks. But this is very, very good as far as DC twins are concerned, because none of these babies are at the risk for prematurity, and therefore you would follow the same guidelines as you would in singleton pregnancies. But here the onus is on the smaller baby. You will try to save the smaller baby at any cost, because beyond 32 weeks, you know you're looking at close to 100% survival, and all these babies can be delivered by 36 to 37 weeks. So late onset FGR is an entity in DC twins, but with excellent outcomes, and know very well that you are going to deliver based on the smaller baby. Now let's look at the summary of all the things that we heard in DC twins. Whenever you have a smaller baby, you remember that you should look for anomalies, but at the same time understand that they could have differing growth potentials. You do your monthly scans and do your Doppler every time that you do a growth scan. If you find that there is a discordance of greater than 25%, even if these babies are above the 10th centile, they are supposed to be having an issue, and therefore they should be followed up very closely. You go in for expectant management in 30 weeks, and after 30 weeks, you will deliver based on the smaller twin, and co-twin demise is not an indication for preterm delivery. You have to try and push this pregnancy till 36 or 37 weeks. Now that was the easy part, because it's similar to singletons. We have very clear-cut guidelines as far as DC twins are concerned. But in MC twins, that is not the case. In MC twins, there are no guidelines because there is very limited evidence out there on how to manage these fetuses, and it's still not very clear on what the best form of management would be. And the last and the easiest systematic review that has come up is this one, which came out in 2019, again from Bhaskar Tilaganathan's group, which looks at this particular problem and has given us a few guidelines, which I'm going to share with you in the next few slides. The first problem basically in MC twins is, why do you have growth restriction in MC twins? What is the reason? It's not bad placenta, it is unequal placental sharing. Now, if the placenta was bad, both these babies should be small. When you have unequal placental sharing, it means one baby is growing well and the other has a poor share of the placenta. And because of a poor share, it is going to be smaller. Whereas in DC twins, it's because of placental dysfunction. So in MC twins, it's because of unequal placental sharing. And to compound problems for the MC twin, there are vascular communications which are running through the placenta, and which is going to make this problem a little bit more difficult to manage. So again, to stress upon this fact that the smaller baby is going to have a lesser share of the placenta, and the anastomosis is what is going to create a problem. And in monochorionic pregnancy, there are two kinds of anastomosis that you should understand. The first one being the deep anastomosis, and the other one being the superficial anastomosis. Now, deep anastomosis are anastomosis that run in the body of the placenta, in the cotyledons. So here it's usually an arteriovenous anastomosis. Blood comes in via the artery and goes via the vein. So that's an arteriovenous connection that happens within the cotyledon. And here the blood flow is always going to be unidirectional. It's going to be from the artery to the vein. And when you have more arteriovenous connections from one side to the other, it means you will have blood flowing preferentially from one side to the other, and that can lead to TTTS. But that's not what I'm going to talk about today. What I'm going to talk about today is superficial anastomosis. Now, superficial anastomosis are blood vessels that run on the surface of the placenta. They do not go within the cotyledons. They run on the surface of the placenta, and they could be arterioarterial or veno-venous. And because they are similar vessels, artery to artery or vein to vein, they're going to have bidirectional flow. And that flow is directly dependent upon blood volume on either side. Wherever there is more blood volume, blood will be pushed from one side to the other. And whenever there are pressure fluctuations, for example, if there is bradycardia in one fetus, then blood will flow from the other fetus to this side. If there is hiccups on one side, then again, blood will flow from the side where there is hiccups to the opposite side. So it's basically dependent on blood volume and pressure fluctuations. That's why in arterioarterial connections, you're going to get bidirectional flow. And it is protective against TTTS. So how is it protective? If you have unbalanced AV anastomosis flowing from one baby to the other, what will happen? There will be increased blood volume on one side. And if there are balancing AA connections, all that blood volume from the side that has more blood will flow into the opposite side, creating a sort of an equilibrium. And that's why it's protective against TTTS. But in selective IUGR, it works like a double-edged sword. And to understand how it works as a double-edged sword, you need to understand three concepts. The first one being feto-placental discordance, the second one being the concept of rescue transfusion, and the third one being collision point. Now, what is feto-placental discordance? If you look at monochorionic pregnancies and you find that a baby is small, you would find that its share of placenta is even smaller. There is no match between the size of the placenta and the size of the baby. The baby somehow continues to grow in spite of having a small share of the placenta. And that happens because of these AA anastomosis. If you look at this example, you can see that this baby in blue has got a larger share of the placenta, whereas this baby in red has a lesser share of placenta. Therefore, the blood volume is going to be more on the blue side. And because of that, blood will flow through the arterioarterial anastomosis into the smaller side and perfuse the placenta of the smaller baby. And that is what is called as a rescue transfusion. The smaller baby is now able to grow because all that blood flows from the blue baby and keeps the smaller baby alive. And that's why it is a very important tool in keeping the smaller baby alive. And how is it clinically important to us? If you look at a singleton pregnancy, and if you have absent end diastolic flow in the umbilical artery, you would say that you have maybe around 3 weeks before it becomes DV reversal and the baby dies. But in monochorionic pregnancies, because of the arterial anastomosis, that week interval between absent end diastolic flow to reversed end diastolic flow and DV reversal is going to be longer, and it's as long as 11 weeks. Now, how is it clinically significant to us? Let's say you do a scan of a monochorionic pregnancy and you see that one baby is small and the smaller baby has got absent end diastolic flow at say 21 weeks. If it was a singleton, you would be very worried. But in monochorionic pregnancies, you know that you will get 11 weeks from 21 weeks. If you do the maths on that, 21 plus 11 is 32 weeks, and immediately you come into the period of viability and you can save both these babies. And that's why it's called rescue transfusion, because it allows this baby to continue to grow in spite of having a lesser share of the placenta, in spite of having a severe abnormality in the umbilical artery. But it is a double-edged sword. Now, why it is a double-edged sword is, I told you that blood volume is one factor that governs flow from one side to the other. Another factor that governs it is pressure changes, bradycardia, hypotension, all those things can affect flow across the arterial anastomosis. Now, in the unfortunate event that one baby dies, if one baby dies, then what happens is that all the blood from the larger baby is going to just flow and drain down into the smaller baby, and which can result in death of the larger baby or neurological damage. So what was a blessing for the smaller baby can turn out to be a curse for the larger baby if the smaller baby dies. And that's why it's called a double-edged sword. And it's important to understand that when the smaller baby dies, you're looking at a 25 to 30% risk of the larger baby dying, or a 30% risk of neurological damage. And that's why the cornerstone of management of monochorionic pregnancies is to prevent the smaller baby from dying, unlike in DC twins, where we're not that worried if the smaller baby dies before the period of viability. So how do you make out this diagnosis? You need to do serial growth scans. You need to do it from 16 weeks onwards. You have to do serial growth scans on a fortnightly basis. You have to do them using your singleton growth charts and do your Doppler in every visit. And when you try to make the diagnosis of SFGR in monochorionic pregnancies, you use the same criteria used in DC twins, the only addition being that you're going to also look at the abdominal circumference as one of the contributory criteria. So if any 3 out of 4 of these criteria become positive, then you would call this selective FGR or growth restriction. Now, once you have made the diagnosis of growth restriction and you know that one baby is small, you need to know something else. And that something else is the share of the placenta. Is it possible for us to actually predict the share of the placenta by looking at the umbilical artery of the smaller baby? And that's what was proven by Edward Gratakos's group. And that's how they brought about this classification of dividing the SFGR baby into 3 types, type 1, type 2, and type 3. Now, why is this division there? This division is there not just to tell you whether the umbilical artery is good or bad, but to indirectly tell you what is the share of the placenta of each of these babies. You know that when one baby is small, it's going to get a lesser share. That we know, because that's the cause of growth restriction. But how bad is that share? And that you can assess by looking at the umbilical artery. So if the umbilical artery has got good diastolic flow, it means that the share of placenta is less, but not very less. So that would come under type 1. But if you have persistent absent or persistent reversal of flow within the umbilical artery, then you know that the share of the placenta is very less, much less compared to type 1. But if you have intermittent absent or intermittent reversal of flow in the umbilical artery, it means the share of the placenta is very, very less. Now, how did we come to that conclusion? I'm going to tell you that in a couple of slides. But first, let's understand about type 1. In type 1, the share of the placenta is less, yes, but there is still diastolic flow within the umbilical artery, which means that it's less, but it is good enough to get an intact survival of greater than 98%. So if you make a diagnosis of FGR type 1, you're looking at a very good monochorionic pregnancy with a 98% survival, with only a 3% chance of unexpected fetal demise, which you can easily prevent if you're going to follow up these pregnancies, as I told you, on a fortnightly basis. Only a quarter of them are going to progress into type 2. In type 2, there is absent end diastolic flow. So the placenta is slightly smaller, much smaller than type 1, but bigger than type 3. And here you know that there is a problem, but you also know that there is a rescue transfusion, and therefore the rate of progression is slower. Remember what I told you, you're going to get 11 weeks. The risk of IUFD is slightly more than the 3% that you saw in type 1. It's around 16.6%. with an intact survival of 83%, which is still good. And if you follow up these pregnancies, you can take them up to 32 weeks comfortably without any issues if you follow the protocol that I just talked about. But the problem comes in type 3. And I told you in type 3, it's intermittent absent or intermittent reversal. And I also told you that the placental share of this type is going to be the least. And why did I say that? For that, let's go back to understanding the arterial anastomosis. I told you that there is bidirectional flow, and I also told you that it is governed by the size of the placenta, by the volume of blood flow. Larger the blood volume, more amount of blood is going to flow into the smaller baby. But it is also governed by the size of the vessel. If the arterial anastomosis is large, it means large amount of blood is going to flow from one side to the other. And that's where you should try to understand this concept of collision point. And what is collision point? I told you that there is an arterial anastomosis and there is bidirectional flow. Let's imagine that this green car is fetus A and the blue car is, say, fetus B. Now, if they have equal volumes, equal sizes, the placental share is perfect, what will happen? Blood will come from both sides into the artery, and the arterial flow will meet at a particular point, and that point is called as the collision point. And in a good placenta, where there is equal sharing and no FGR, the collision point will be in the center of the placenta. And all the pressure fluctuations that can happen because of hypertension or bradycardia or hiccups will be happening within the placenta and will not be evident to us when we look at the umbilical artery. It's happening within the placenta. We're not worried about it. Both these babies are going to do extremely well. But what happens if the placental share is less? If the placental share is less, blood volume is higher on one side. So it's going to flow into the side of the smaller baby. So the collision point is not going to be at the center, but it is going to be into the side of the smaller baby. And because of that, it is helpful because it creates what is called as rescue transfusion that I just talked about, and it is going to keep the smaller baby alive. So even now in type 2, where the placental share is less, the collision point is still within the placenta. And we cannot see the pressure fluctuations because it's happening inside the placenta. But what if the placental share is very, very less? When the placental share is very, very less, and if the arterial anastomosis is large, greater than 2 millimeters, then the collision point is going to come all the way from the placenta of the larger baby into the smaller baby and into the umbilical artery of the smaller fetus. So in the umbilical artery, the collision point is going to be seen, and because of that, all the pressure fluctuations that are going to happen because of bradycardia or because of hypertension or hiccups is going to be evident within the umbilical artery of the smaller baby. And that's why when you look at the umbilical artery of the smaller baby in type 3, you're going to get intermittent absent, intermittent reversal, good diastolic flow. All these things you're going to see because now the collision point is within the umbilical artery of the smaller baby. So you have a large placenta, very small placenta. Obviously, it is going to push blood flow into the side of the placenta of the smaller fetus, all the way up into the umbilical artery of the smaller fetus. And that's clearly shown in this placenta. But you can see that the share is so very less. And this large arterial anastomosis is running all the way up to the smaller baby, taking the collision point into the umbilical artery of the smaller fetus, and thereby creating this intermittent absent or intermittent reversal of flow within the umbilical artery. So that's important for us because it actually tells us that type 3 has got an intermittent pattern because its placental share is less, and the collision point is near the placental insertion site, which means you can pick it up only if you sample near the placental cord insertion. And that goes against our dictum where we have always said, look at the free loop, look at the free loop if you're looking at growth restriction. That's what we have been taught. But in MC twins, it is an exception. You have to look at the placental cord site. Now, this has the poorest outcome because it's unpredictable. We cannot say when this baby is going to die. And we're looking at a dismal survival of less than 61% with a high IUFD rate of around 13.2%. Now, this is an example that I can show you. You hear this patient was referred to us as SFGR. And yes, one baby is small. The fluid is less on one side, normal on the other. And it was referred to us as SFGR type 2. And yes, the free loop was showing persistent, absent, and diastolic flow. But I want you to take a closer look at the cord insertion near the placenta. What can you see here? You can see red, and can you see a little bit of blue coming in between? So it tells me that the collision point is not in the placenta, but within the umbilical cord. And we revised our diagnosis to type 3 because we had intermittent absent, intermittent reversal of flow, telling us that the placental share of this fetus is very, very less, and we cannot be complacent in this fetus. There is a possibility of unexpected fetal demise. So the take home on types of SFGR is that remember to look at the placental site. Unless you look at the placental site, you cannot make the diagnosis of type 3. And remember that, that there can be different Doppler abnormalities across the umbilical cord, but always take the worst form to make your classification. And also remember that have a very slow sweep speed while assessing the Doppler waveforms. You need a very slow sweep speed because if you take a high sweep speed, you can miss out on abnormalities like this, which can only be seen if you allow the trace to run for a longer period of time. So keep it close to the placental insertion site and also have a slow sweep speed. Now the management part, now we've understood how to make the diagnosis, how to classify it into different types, how the sharing of the placenta is important to us. Now we come to the management type and management part. And it's again very important to understand that the cornerstone is to prevent co-twin demise. We don't want co-twin demise at any cost. And as far as possible, we need to prevent iatrogenic prematurity of the larger twin. So again, the parameters that we're going to use are the same parameters that we used in singletons: Doppler, biophysical profile, and CTG from 30 weeks onwards. The same parameters that you use in singletons. So the management options that we have are basically to go in for preterm delivery if you find that the smaller baby is going to die, but that is only possible after the period of viability. Selective reduction if you feel that the smaller baby can die before the period of viability and you want to try to push this pregnancy beyond the period of viability, you can go in for selective reduction. And finally, expectant management if both babies are doing well, and it's especially in type 1 and type 2. So in type 1, as I told you, excellent prognosis, very good share of the placenta. You just need to look at them on a weekly once basis, do your Dopplers, do your CTG and biophysical profile from 30 weeks onwards. You can comfortably take them up to 34 and 35 weeks. So this is the best form SSFGR you can get, where you will have 2 happy, healthy babies at the end of that pregnancy. In type 2, we need to decide whether we need to go in for expectant management, which means we believe that the smaller baby will go beyond the period of viability. If not, the other option is to go in for selective termination. So this is the decision that we need to make when we make the diagnosis of SFGR. We have to ask ourselves if the smaller baby will reach the period of viability or not. And if not, is it going to die in utero and put the larger one at risk? And that we can do by looking at certain specific criteria, which are called as preemptive criteria, which are actually trying to predict whether the smaller baby will reach the period of viability or not. So for that, you look at the gestational age. If you have a baby that is growth restricting at a very early gestational age with a severe discordance of greater than 35%, with a severe abnormality within the umbilical artery, like a reversed diastolic flow in the umbilical artery, or a DVPI greater than the 95th centile, then we know that this baby cannot cross the period of viability, and therefore we have to take a decision of selectively reducing the smaller baby in order to try to save the larger fetus. So how do you decide that? Look at the gestational age, look at the degree of discordance, and look at the severity in the umbilical cord. And if any of these things are present, you can go in for selective reduction. But if none of these points are present, for example, the baby is having a growth discordance of just 25% and the umbilical artery is showing persistent absent end diastolic flow, we can wait. And then when we wait, what are we looking for? We are basically trying to again do the same thing. We are going to try and predict if the smaller baby is going to die in utero or not. So how do you predict fetal demise before the period of viability? You look at the ductus venosus, exactly in the same way as you do in singletons. In singletons, we look at the ductus venosus before the period of viability, before 30 weeks. And if you find that the DV is reversing, what do? We try to deliver the fetus, as in singletons. But in monochorionic twins, when we find that the DV is reversing before 28 weeks, we do not go in for preterm delivery, we go in for selective fetal reduction, because we know that this baby, the larger baby, will not survive in the extrauterine environment, and therefore we decide to sacrifice the smaller baby and cut off its blood supply. So when we cut off its blood supply, we are cutting off the arterial anastomosis, and therefore blood cannot flow from the larger baby into the smaller baby. But after 28 weeks, if we find that the smaller baby is going to die, based on the same criteria that you used in singletons, we don't do selective reduction, we go in for preterm delivery, knowing very well that the survival chance is greater than 90% for both these babies after 28 weeks. So the option of selective reduction is only when the fetus is less than 28 weeks and the DV is reversing. In type 3, we know that there is a long latency period. We know that they have got the least amount of placental share, and there is a high possibility of unexpected intrauterine fetal demise. But there is a very big problem with type 3. And the biggest problem here is that the DV will never reverse in this group. Now, why does the DV not reverse in type 3? We know that it has got the least amount of placental share, but it is not reversing when the baby is going to die. The reason for that is because there is intermittent absent and intermittent reversal of flow. It's like getting on the treadmill and running continuously. In SFGR type 2, the fetus is on the treadmill and running continuously and eventually will fail. And we know that after a period of time, it will fail and the DV will reverse. But in type 3, it is as if it's getting on and off the treadmill. Intermittent absent, then there is intermittent diastolic flow, and intermittent reversal of flow. So it gives the heart enough time to relax and recover. And because of that, you are not going to get a DV change or a DV reversal in type 3, but you can get sudden intrauterine fetal demise because of the pressure fluctuations leading to sudden hypotension. And therefore, type 3 is extremely difficult to manage, and we have to be very, very careful. And there is no method to predict demise in that group. And all of them will have elective delivery at around 32 weeks. Now, finally, a bit about selective termination, which I already talked about. There are two options that we have. One is bipolar cord coagulation and radiofrequency ablation. Radiofrequency ablation is usually done in earlier gestations, while bipolar cord coagulation is done during later gestations greater than 22 or 23 weeks. So if you find that the smaller baby is going to die before the period of viability, we use a bipolar forceps and grasp the cord and coagulate the entire cord and thereby cut off the blood supply. And after coagulation of a segment of the cord, this is how it is going to look. We'll get a nice white patch. And because of this white coagulated patch, there is no hypotension that can cause blood to come from the larger baby into the smaller baby. Another option is to go in for radiofrequency ablation, especially at earlier gestations, where instead of going into the umbilical cord, we go into the liver, and there we burn the vessels that enter into the liver, and thereby doing the same thing exactly as we did with bipolar cord coagulation, that is cut off the arterial anastomosis. So to sum up all those things that we learned in monochorionic pregnancies, remember that when you have CRL discordance, or when you have one baby that is small, it is usually because of aneuploidies, anomalies, or selective FGR. Once you know that the baby is smaller than the other, you classify them into SFGR types, basically to know the share of placenta. Expectant management can be done for most of them if they don't fit into the preemptive criteria that I talked about. But on the other hand, if you find that the preemptive criteria are positive, or if you find that the DV is reversing before 28 weeks, then you have to go in for selective fetal reduction based on the criteria that I just talked about. So finally, I hope you would agree with me that the twins, it's not about being good news or bad news, it's just news. And if you learn how to manage them, you're going to have reasonably good outcomes. Thank you. Thank you for listening.
Thank you very much, sir. It was a wonderful lecture, especially that concept of the arterial anastomosis and the collision, and the examples you gave was really, really very good. Anjali, can we have the questions across, please? Mr. Bhaskar?
Yes, ma'am. Anjali, can you just copy the questions?
If any delegate has any question, could you just put that, please, here?
I think they were exhausted with the lecture, probably.
It was a great lecture. I mean, the way the monochorionic and dichorionic explained really, really, really beautifully.
Thank you.
Yes, Mr. Bhaskar. Any leads for the questions?
Sir, you make difficult lecture look very easy.
Okay.
Ma'am, so far there's no question in the chat box.
Thank you very much. Thank you, Dr. Bijoy. And once again, happy Republic Day to all. Jai Hind.
Thank
Good
you so
night.
much. Good night.
Thank you, sir.
Thank you. Thank you.
Thank you, sir. Thank you, sir.
Thank you, ma'am. Thank you, sir.